Good morning.
Good morning.
Another second and we'll get going. Okay, so this is a teenager, and this is the electrocardiogram that was obtained on this patient in tachycardia. So I'm going to ask Dr. Neha Lawalia what she thinks the mechanism is of this tachycardia, if possible to tell from here.
All right, so I don't see clear P waves preceding any QRSs. The QRS does look a little wide, but I don't have those boxes to help me, but I do see a deflection after the QRSs, which seems to be consistent. And so I think based on that, and the rate, do we know the rate? It's
the rate, let's say, since there's no boxes, let's say the rate is 210 beats per minute. So on the right-hand side, it's 215. On the left-hand side, it's 212.
Okay.
So
I see
here,
it's changing.
12, here,
Right.
14. How's that?
Yes. So basically, the QRS morphology, as you pointed out, from the beginning of the screen to the end of the screen is changing. Based on the P waves, based on the retrograde P waves that we are able to see, it's likely an ORT from a pathway, like a pathway mediated tachycardia. And then because we have been lucky to capture the warming up period, I know there's a way so based on the bundle branch morphology, we can tell which sided pathway it can be. And it looks like right bundle.
Does that look like the right bundle?
No, sorry, let me see. It's a left bundle branch block. So it's the opposite, right? It's a right-sided pathway.
No, when it's when you got it right up to the end. So give you full credit for that. But no, when it's the ipsilateral side. So
Ipsilateral.
So you're right. So it's a wide QRS that becomes narrow. Now it's possible that these are two different arrhythmias, but it's much more likely that this arrhythmia is the same, right? Why would two rhythms or two QRSs that are fast be almost exactly the same rate? It would be kind of bad luck to go from VT to SVT, right? So as you said correctly, the tachycardia is warming up, so there is bundle branch aberrancy as the bundles are warming up, as they say, until it narrows. And the R-to-R interval on the left-hand side of the screen, as I explained, is slightly wider than the R-to-R interval on the right side, or the left versus the right. And so basically, if you think about it this way, when you have orthodromic reentry, you're going down the AV node and the bundle of His, down the bundle branches to the ventricle and then back up the accessory pathway, such as this, okay? If you have a left bundle aberrancy, and again, this is a random event. In other words, there's no way to know this, but if the left bundle is what am I trying to say? If there is a left bundle, that means by definition that you can only go down the right bundle. And so the cycle length of tachycardia is going to be longer if the pathway is on the same side. Now, if you had a left bundle and you had a right-sided pathway, it would not affect the cycle length, okay? But if you have a bundle branch block in the setting of orthodromic reentrant tachycardia, and if the tachycardia cycle length lengthens, then that's a good sign that you have an ipsilateral accessory pathway, because if there's bundle branch block, it means the only way to go up to go down to the ventricle and then come back up that pathway is to go through the contralateral bundle and then depolarize the ventricle in this awkward manner back up to the A. So the next day will be late, meaning the ventriculoatrial time will be longer, but the easier thing to tell on a surface electrocardiogram is that the R to R interval is a little longer than it is when you're not having the bundle branch block. So if you are lucky enough to see, and the R to P interval is certainly greater than 70 milliseconds because we clearly see a retrograde P following each QRS. So if we are lucky enough to be, as you aptly said, Neha, to have a bundle, and we can tell which, whether it's a right or a left bundle, which in this case, of course, we can because we have 12 leads of an ECG, then you are able to then determine if it is a right or a left-sided pathway. And in this case, because there is a left bundle morphology, we know that with a lengthening of the cycle length in the setting of a left bundle morphology, it must be a left-sided accessory pathway. And this is important because it might alter when you would decide to ablate somebody if the pathway were right-sided and mapped close to the AV node in the setting of, of WPW, or let's say if it was a concealed pathway, you would want to know this. One of the reasons we don't ablate small children is because we're always nervous that the pathway is going to end up being right next to the node. But in this particular case, we see pretty clearly that the pathway is quite remote from the node because it's a left-sided pathway. And so I certainly have had this circumstance where I've seen this in an infant, and I've recorded it in my notes so that I remember in the future, particularly if the patient is not pre-excited, because there would be no other way to know whether the pathway is right or left-sided. Many, many years ago, when Jared Lacourt was a fellow, he made this diagnosis. Actually, he had just finished his fellowship. He made this diagnosis like in his first month in practice, and I remember being very impressed that he understood this concept. So good job, Neha. That was not easy. Okay, this is a 30-year-old single ventricle Fontan who is not feeling well. And I'm going to ask Uzoma Obiaka, soon to be of Alabama, what she believes is going on here.
Good morning, Dr. Paz. So looking at this, we have a narrow complex rhythm with a rate of about maybe 110 to 120 thereabouts.
Yep.
And looking at the rhythm strip, I don't see any obvious P waves. But let me go back. So yeah, looking at the rhythm strip, I don't see any obvious P waves. I see deflection that might be a T or might be P wave with a prolonged PR interval. But if I go back, yeah, I'm talking of that deflection there. Yeah, so that I'm wondering if it's a T or a P with a prolonged PR. But then right after the QRS on the T, there's like another deflection.
You're talking about this or
yes.
down? Oh, this here.
Yes. So this, yeah. So that's another deflection, but I don't see in other strips. So I don't think that's
Yeah,
I don't think that's of importance.
that's a good way to determine whether
Uh,
you're looking at a retrograde P wave or not. Is if you don't see it's a similar deflection in other leads, then it's probably more likely just part of the morphology of the QRS and not a retrograde P wave. So that's a good way to look at it. I like that idea. So
okay. So yeah, so I don't see any obvious P's, and I don't have a prior EKG. So I'm wondering if this is, and again, like I said, the QRSs don't seem wide. So one alternative I have is if this is a junctional rhythm in this patient, maybe some sinus node dysfunction, and the patient is in some junctional rhythm.
well, if somebody were junctional at 110,
that would not.
would that be consistent with sinus node dysfunction?
No, actually, that's faster. That would be like an accelerated junctional.
Right.
Um,
So are
and
you familiar with any accelerated
So-
junctional rhythms that 30-year-old Fontan patients
so
get?
30-year-old Fontans are more likely to have more likely would be in a flutter kind of rhythm. But I'm looking in my V1, I'm looking in my V3, and I don't see sufficient evidence to call this flutter.
So this is a
So-
very, this is a good example of how hard it can be to tell in a Fontan if someone's in flutter. This is flutter, and you should always, when you are, whenever you see a Fontan patient who's, let's say, over the age of 10 or 15, they basically should never have a heart rate over 100. And if you see this, the burden of proof is to prove it is not flutter. I'm not suggesting that it's not possible to be in sinus tachycardia as a Fontan at this rate, but sort of like, how we say wide QRS tachycardia is VT until proven otherwise. I would say any Fontan with a heart rate over 100 is IART until proven otherwise. Okay. And in actuality, if you look here in V2, this little blip here, which you can see evidence for some kind of a secondary hump on the T waves in a number of different leads, which absolutely you could have read out as just being the T wave, and you would not have been wrong. But in fact, there is a little P wave here. So this is actually one-to-one IART, and this patient ended up getting cardioverted, I believe, and got an ablation. So point is, and I've seen some very experienced cardiologists send a Fontan patient home from the office and then had the EKG reviewed by a colleague to find out that they had missed flutter. So always keep in mind that when you see a patient at this rate, it is possible it is atrial flutter. All righty. So this is a patient who is in tachycardia, and a PVC is placed into the tachycardia. And I'm going to ask Dr. Sergey Babia to answer if he can tell whether this has helped us to figure out what the diagnosis of this tachycardia is. I should tell you that the tachycardia rate is, well, it's cycling 460, right? So we divide our 60,000 by 460, it's a rate of 130 beats per minute. And just to remind you, whenever you're looking at these tracings, we look here at top 4 are surface in this particular example. Actually, top 5 are surface leads. They have an RA lead, a His bundle, just one His channel, RV, and then proximal and distal coronary sinus.
Good morning.
Oh,
So placing a PVC means that we're doing the ventricular extrastimulus testing.
not necessarily. But it's possible.
Mhm.
But remember, we are in tachycardia.
Um, so I'm looking at the place where the PVC comes in,
Mm-hmm.
and after that, 5. After that, it looks like not sure.
Okay, so just hold on one second. Okay. Okay, so let's go through this. So the patient is in tachycardia, and here's the QRS. So that means when we're looking at these tracings, if this is the QRS, then all of the signals below it correspond to which, the V or the A?
V.
The V, right. So we have all of these V's in the HIS, the RV, the proximal and distal CS. And then, of course, the signal that follows it is going to be the A. Now, in this case, the earliest A is in either the right atrium or in the HIS, right? I think you would agree with me that these are fairly close in timing between each other, right? If you look on each beat. Although it looks like the IRA is a little earlier, right, than the HIS-A. So we have A going down the AV node, HIS deflection here, this little HIS, V, A, HIS, V. So again, so the question is, now, normally, if we were in AVNRT, would the A be earliest in the HIS or in somewhere other than the HIS?
In AVNRT,
Yes.
it will be faster.
So in AVNRT, the earliest A should be in the HIS, right? Because reentry is occurring right next to the bundle of HIS. So theoretically, if you imagine that the reentry is occurring right above the level of the HIS, the retrograde A or the A should be basically very early in the HIS pairs because it's essentially arising from the level of the HIS, right? That's where the reentry is right there, right above the HIS. So we would expect that the earliest A in AVNRT would almost always be in the HIS pairs. So in this case, I think we've agreed that the lateral right atrial signal is a little bit earlier. So that in and of itself is pretty good evidence that we are not in AVNRT. Also, what is the typical R to P interval in AVNRT versus ORT?
Less than 70 milliseconds.
Right, less than 70 milliseconds. And although we don't have markers on here, I think we would agree that this is a longish R to P interval. And so this also does not go with the possible diagnosis of orthodromic reentrant tachycardia. But one of the most important maneuvers that we always do, and Dave Barris and I discussed this last week when we did a case of AVNRT, is that we place a PVC on top of the HIS or simultaneously with the HIS. And you can see when we put the PVC in, the QRS morphology changes, suggesting that we captured the ventricle. Now, this is, so again, what we're talking about are putting PVCs in tachycardia during HIS refractoriness, okay? Now, if the HIS, so in ORT, we're going from the A through the AV node, through the HIS bundle, and then through the right and the left bundles, down to the ventricle, and then we come back up the accessory pathway, and down again. Okay, so that's ORT. Now, if I put a catheter in the right ventricle, as we do during an EP study, and I place a PVC at exactly the moment that the His has fired, well, if the His has just fired, then it's refractory. However, if you're in ORT and I put that PVC in at the moment that the His has fired, then that means that I will depolarize the ventricle, both the right and the left ventricle, earlier than I would if I were to allow the ORT to just progress, because I'm pacing the ventricle basically down here, and I'm doing it before the time it takes to go from here down to here with the electrical impulse. So if that were the case, then Sergey, when would the next A be? Would the A be on time? Would it be early if I put a PVC in at the moment that the His bundle fired in ORT?
It's going to be early.
It's going to be early, exactly, because I will depolarize the ventricle. Whatever length of time it takes to go from the bundle of His to the ventricular apex, I will be gone. That will be how much earlier the next A will be, because I will be depolarizing the ventricle with my PVC and causing the impulse to go up the pathway a little bit faster, because the A will come sooner because I will be depolarizing the ventricle quicker than it would be in ORT. Now, contrast that with AVNRT. In AVNRT, we have the reentry occurring at the level of the AV node above the level of the His. And then we have the right and the left bundles. Now, if I put a PVC in at exactly the moment that the His has depolarized, that means that the His will be refractory, which means that if I put a PVC into the ventricle at the moment that the His has fired, when will the next A be? On time or early?
On time.
Why is that?
Well, because it's above the His.
Because it's above the His, and because the only way, in the absence of an accessory pathway, to conduct from the ventricle to the atrium is through the bundle of His. So if the His has just fired, it's essentially a gate that is disallowing ventriculoatrial conduction temporarily because the His has just fired. And that's different than in ORT, because in ORT, if I put the PVC in, the His will be refractory and I cannot go up the AV node. However, there's an alternate way to go from V to A, which is the accessory pathway. So very importantly, in ORT, if we put a PVC in during His refractoriness, the following A will be early. But if we put a PVC into AVNRT at a time of His refractoriness, the next A will be on time. It will not be early. And so if we look at this tracing, what we see is, so we have a lot of evidence already without this maneuver that this is not AVNRT. First of all, we see that the earliest retrograde A is in the RA. The second thing we see is that the VA time is greater than 70 milliseconds. So you could make the argument that we already know that this is not AVNRT. However, the timing of both the His A and the lateral RA, they're fairly close to each other. They're probably only a millisecond or two off from each other. And so it is conceivable that this could still be AVNRT. It could be an atypical form of AVNRT. So putting the PVC in, remember, if a PVC advances the next day, then it is ORT because of this fact that we can go from ventricle to atrium through the extra pathway. If, however, a PVC does not advance the A, then it's AVNRT. So this is a very nice and elegant way to prove whether we are looking at AVNRT or ORT. And in this case, putting the PVC in at exactly the moment that the His has fired results in the retrograde or the next P wave coming in at 425 milliseconds, whereas the cycle length of tachycardia is 460, meaning that a His refractory PVC advanced the next day. And that would be consistent with the diagnosis of ORT. Okay, so once we do that, then we really have cinched this diagnosis. Does that make sense?
Yes, thank you.
Okay, so this is a test that we try to do in all patients when we get SVT in the cath lab, is to figure out if a HIS refractory PVC can advance the following A. If it can advance it, again, it's ORT. If it cannot advance it, it's AVNRT. Those are not hard and fast rules, but they're pretty good most of the time. Okay. All right. This is a heart rate trend on a 3-month-old with a history of SVT. So I'm going to ask Dr. David Barris what he thinks, just based on the trends, is the most likely thing that's going on here.
I would say most likely a reentrant tachycardia, just because it's a rapid increase as opposed to a warm up. But that way we'd see with an automaticity tachycardia.
That's exactly right, David. And in fact, you might be fooled because the slope seems to be a little bit, it's not quite straight up in the air, but that's a reflection of the time scale. Notice the entire time scale here is only 50 minutes in duration. So time has been expanded, and it looks like it looks slower onset than it actually is. And the other thing that goes with it being reentrant is the fairly consistent rate, right? When we're in tachycardia, almost looks like a straight line. So that would also go with reentry. So very important to always look at the heart rate trends when you're trying to make a first analysis of an arrhythmia, if such a trend exists. Okay, this is an example of a patient who has received IV propranolol. And I am going to ask Dr. Perna Bonsall, who has been arduously working all weekend, to tell me what the effect of propranolol seems to have been in this patient.
Good morning, Dr. Pash.
Good morning. I should say good day. You and I have been talking continuously 24 hours.
So if I look at the surface ECG lead 2, the control and one with propranolol 10 milligrams IV, looks like the PR interval has increased, and that reflects in the increased AV interval in both HRA, coronary sinus, and then AH interval is clearly increased in the HIS bundle.
So where is the block, or where is the?
So block is at the level of AV node.
Correct, exactly. So this is a nice demonstration. And you said it exactly right, Perna. That was really excellent. When you give propranolol, the PR interval lengthens. And so you did it exactly right, which is you looked first at the surface electrocardiogram and clearly noticed that the PR interval got very, very long compared to the control. And we see that in the HIS pair, that the effect of propranolol in this case was predominantly at the level of the AV node. And this is basically one of the most important reasons why we use propranolol in general, is that we're using it for 2 reasons when we're treating SVT. The first reason is that it reduces the number of PACs patients have, because as you know, PACs are what induce SVT. Oftentimes. But the other reason is that we are trying to essentially poison the AV node to make it harder for the PACs to conduct and start tachycardia. And this is a nice example with intracardiac tracings of what the cause of slowing is in the AV node with propranolol. And by the way, we almost never use IV propranolol. Every once in a while, this will come up in an infant who's NPO. I would strongly dissuade you from using IV propranolol in infants. If you're going to use an IV beta blocker, the only option really is esmolol. Propranolol tends to be dosed improperly, and you could get an effect like this, which is obviously suboptimal, and it sticks around for a long time. So it can cause hypotension. So you should really not use IV propranolol, as opposed to, say, digoxin or any of the other IV agents like procainamide or amiodarone or things like that. All right, this is a 21-year-old about to undergo a cholecystectomy and is in the emergency room. And this ECG was obtained as a screening tool. And the doctors want to know if there's anything to be concerned with here. So I'm going to ask Dr. Neha Lawalia what she thinks about this tracing.
So just looking at the rhythm strip, it looks like sinus. I see P waves before every QRS, and they're upright in one and AVF. So looks sinus rhythm. The rate, it's bradycardic. The rate, I would say 3, 4, 5 is around 60. 21-year-old, so it's probably fine. The rate is fine as well. The axis looks okay. The voltages are just a little dampened.
Yes.
And it's a full standard EKG.
Good question. I should have given you that. Yes, this is full standard.
So from that standpoint, yeah, that's the one thing that I would say is abnormal.
I would agree with you on that. So what is the most likely cause of low voltages in any individual?
Think it's just like body fat or something. If you can't
It's
capture
what?
that.
Sorry? Body
If
fat?
it's like,
Is that what you said?
yeah, yeah, or the leads. I don't know. We see this quite often and has not been pathological, but I would say
That's right. Well, you're
pericardial
right. It is. You are
Yeah.
correct that it is most likely just a normal variant. And I have here. So low voltage
Diffusion,
QRS is defined as less than 7 millivolts in the limb leads or less than 10 in the precordium. And I think in this case, clearly we meet those criteria.
Mhm.
And the differential diagnosis is pericardial effusion, cardiomyopathies, hypothyroidism, as you said, obesity, sarcoidosis or amyloidosis, COPD, anasarca, which we've seen on rare occasion, and then most important of all, normal variants. So if you see this type of low voltages, you do have to be concerned though for all of these other possibilities. So I would say, you know, how urgently you would get an echocardiogram would depend on how urgent the need is to go to the operating room. Most people can at least have an echo before they have cholecystectomy, I would say. All right. What happened here and what does it practically mean? This patient received this is incorrect. It's 1 gram of procainamide. This is a teenager. And so I apologize for that. So this patient received 1 gram of procainamide, David Barris. And what do you think happened here and what does it mean?
Let's see here. So the first deflection that I see is in our high right atrium in the first beat. And then I see our His catheter and I see our AHV all very close together. We see that our AH interval on the top there is labeled for us as 90. And then I'm kind of moving along the screen just to see if there's any changes. The voltage does change in lead 1 as we move to the third beat. Our AHV stays pretty similar. We say that our HV is 42. And I guess so the biggest changes we see in lead 1 and the surface leads where we had that maybe a delta wave that's a little bit more narrow now.
Mm-hmm. Yeah, I think that D, this is not, I stole this tracing, but I think this D is meant to denote delta.
Yeah, I should have seen that too. Yeah.
But I didn't actually see that till now myself. So we're both guilty of not paying enough attention. So, this is a nice example of how the surface is the surface is your friend when looking at intracardiac tracings. Yes, that'd be my quote of the day. And I think you said it, David, that it looks like we're pre-excited on the left-hand side in the first 2 beats. And then in the last 2 beats, we're not pre-excited after a dose of 1 gram of procainamide. So what do you think this means? If you essentially what's happened here is we've lost pre-excitation, and the author of this figure is essentially telling us, is an HV of 42, is that a normal finding in humans? What is it?
Yeah, that's normal. It's
Yeah,
like 30 to 50.
Yeah, it's like 35 to 50. So that's a very normal HV. So they're essentially saying that on the right-hand side, and when you're pre-excited, what happens to the HV interval?
I think it would get smaller because
Yeah.
you're pre-excited.
That's right, because the pathway will cause depolarization of the ventricle earlier than it normally would. And so the H to V interval, because you're not going through the His-Purkinje system, you're going through the pathway. So we have a normal HV interval after a dose of procainamide. So I'll just tell you what this means, because this is something that used to be done all the time in the era prior to ablation. And remember that catheter ablation really only began in like 1989 when they used a DC current to ablate. And then in the early 90s, we started to use radio frequency energy. I often marvel at the fact that when I started my fellowship in electrophysiology, the team in Boston had only been doing RF ablations for 4 or 5 years, which is really remarkable. It seemed at the time like they were such experts and so profoundly experienced. And to this day, I think everybody who trains always will think of them as being so much more experienced. But in reality, at this point in my career, I've done many, many more ablations than any of the gentlemen who taught me how to do ablations ever did at that time. But it's just a testament to how brilliant they all were, that they knew so much about ablation, even though catheter ablation with RF energy was only maybe 4 or 5 years at that time. So before the era of ablation, we would, if you had a patient come into the hospital with rapidly conducted atrial fibrillation, or had even suddenly died and had been resuscitated, they had to be put on an agent to block the pathway to prevent this from ever happening again. Or they had to have surgical ablation. So it was very common that you would take the patient to the cath lab and you would give them 1 gram of procainamide to see if you could block the pathway. And if you could, then that was a good sign that if you put the patient on procainamide, that you would prolong the effective refractory period of the pathway adequately to protect the patient. So procainamide used to be a very typical drug that was given to difficult WPW patients in an era prior to ablation to prevent sudden cardiac death. And this would be a very common test that was done in the cath lab to prove safety for someone with WPWs. It was a procainamide challenge, essentially, or test. So very different than when we give procainamide to bring out Brugada syndrome. But in this case, the goal was to see if you could block the accessory pathway. And if you could block the accessory pathway, that was good indirect evidence that the pathway, that on procainamide, the patient was protected from the possibility of sudden cardiac death. So this would be considered a good finding. And then the patient would likely be sent home on procainamide, which comes in very large tablets that are, even the long-acting procainamide is a twice-a-day medicine. It's called Procan BID for BID, and that's the long-acting version. And it requires, like, I think the smallest dose is something like 1,000 milligrams. So you basically have to be an adult-sized patient to take it. And procainamide has a lot of side effects associated with it. And so you almost never see us using this agent any longer for that, because we can ablate these patients. If we see someone with a dangerous pathway, we would just ablate them. But this is a nice example of the loss of pre-excitation, the normalization of the HV interval. Remember that the HV interval is measured from the H to the earliest V in any lead that is being displayed on the computer. And so if we look at the pre-excited beat, in your mind's eye, I think you could say that the onset of the QRS, the beginning of the delta wave, is pretty much on time with the H here. So the HV in the pre-excited beats would be basically 0. But on these beats, we see clearly that the V is now starting quite a bit later relative to the His than it was in the pre-excited beat. So we basically go from an AH of 90, an HV of 0, to an AH of 90 and an AH of 42 milliseconds. Another intracardiac proof that the pathway is no longer conducted. And I think with that, we're going to stop. Appreciate you all joining, and hope everybody has a good day. And shout out to Perna Bonsall, who worked very, very hard this weekend, helping us take care of a sick patient. So thank you, Perna, and I'll see you all sign up very shortly.
Thank you, Dr.